Basically, this is the overview. As you know, alloimmunization, the best analogy I have is really is like an allergy. So you're exposed to an antigen, then it elicits some kind of immune response. So it's kind of high time. I use allergy because it's spring and everyone is allergic to pollen. At least I am. I have the severe attacks of sneezing every morning when I wake up. So that's kind of how autoimmunization is. And the main antibody is called the immunoglobulin G, which is actually IgG, which is very small molecular in terms of molecular size and crosses the fetal maternal barrier very easily. It doesn't need a transport system. It just kind of flows through the membrane. And it's mediated through a cell membrane receptor called FC receptors, and it binds into what we call the FC region of that IgG or that antibody. And then from there, it just kind of crosses over. And what happens is that it binds itself to the surface of the cell. The surface of the cell is then recognized as something foreign. And then your white cells, the macrophages, are now going to eat up the cell and then basically destroy the target cell. So among the alloimmunization, the most rare that we see in the US is actually against platelets. But a fairly common alloimmunization if you are in the Scandinavian countries, especially Sweden and Norway. And this is usually because of exposure to paternal alloantigens. So it's actually the union of the couple that actually exposes the woman who will be carrying the child to the alloantigen and then starts developing antibodies. Now, having said that, it's also very much related to the what we call tissue typing or the HLA type. And so if the HLA typing is incompatible, then usually the first child is affected, and the most common manifestation is the intracranial hemorrhage. The next set of red cell alloimmunization that are more common in the US, I think the most that you can identify with is the RHD or the RH immunization. Now, other than the RHD, there are other antigens that are on the surface of the cell. So the more common ones are the capital C, the little c, the big E, the little e, although the little e doesn't really cause significant hemolytic anemia of the newborn and the fetus. Then there's the FYA, which is called the DEFT, and the big K or the CAL. Now, what we do is, like I said, first identify the antibodies. Once you've identified the antibodies, then we would look at the antibody titers. The antibody titer is a measure of how you react to the antigen. So it's like the degree of allergy that you have. And the number we normally look at is 1 to 16. So when we hit 1 to 16, then we know there is a significant amount of immunoglobulins that are running around that can cross over to the placenta. All of them are governed by this 1 to 16 principle for the titers, except for KEL. For some reason, KEL is a lower threshold of 1 to 4 or 1 to 8. And the way KEL works is that it doesn't attack the maturing red cell, but it attacks the precursor red cell. So that's the reason why it's a lot harder to deal with. And in most cases of red cell autoimmunization, the first child is the first exposure. And then the second child, it may or may not be affected depending on the whether the antigen or the antibody reaction is homozygous or heterozygous. Any questions so far? Okay, I'll pause from time to time. So, and if there are any questions, you can interrupt me at any time. So, just kind of a graphic representation of the HLA or the neonatal autoimmune thrombocytopenia, which is the platelets. So, essentially, kind of what I said, the platelets here in number one, carrying the HPA1A antigen, enters into the maternal circulation. And then the mom gets sensitized, and then and then basically starts developing the HPA-1A antibodies, which ultimately will cross over to the placenta. And if the baby is positive for the HPA-1A, essentially then those platelets are going to be target. And they usually target mature platelets rather than precursor platelets. And then that would cause some bleeding, especially in the neural tissue for the fetus, only for the reason the neural circulation is the most fragile in the fetus at this time. Um, Unlike hemolytic disease of the newborn, again, just like the same, there's an exposure in the maternal circulation. You start developing antibodies within the maternal circulation. And this little Y little thingy here that you see, that's kind of the representation of the IgG or the immunoglobulins on how they look like. And then it starts affecting the red cells and then starts to lyse the red cells and destroy it. So another graphic representation, just kind of be more explicit in terms of what we see and looking at the red cell transport system. So maternal red cells by itself doesn't cross the fetal-maternal barrier, but it's this Y-shaped immunoglobulins that can easily enter into this interface. This is villi, which is bathed by maternal blood, and then comes across, and then you see those Y-shaped immunoglobulins binding to the fetal red cell there, and the macrophages will easily recognize these cells to be foreign and starting to phagocytize the cells and destroy them. So what happens to the baby? So essentially, the baby becomes anemic. And then what happens is that once anemia sets into the fetus, the heart has to work as hard as it has never done. And especially in the fetus, the cardiac rate essentially is what drives the cardiac output for the baby and hence the oxygenation of all the organs in the baby. If the heart starts to fail, then you start developing fetal hydrops where there's a buildup of fluid in the lungs, under the skin, some cavities in the body, until later on the heart goes into failure and the baby dies. Then sometimes when we catch this before it becomes stillbirth, of course, then we give the baby steroids, deliver the baby, and then outside the baby can have an exchange transfusion or probably a postnatal phototherapy for hyperbilirubinemia. Do we do so? Before I kind of touch myself there. Okay, so in utero treatment, we do in utero treatment. So if the baby is severely premature and we feel that there is a benefit for the baby to stay in, what we do is the first thing that we do is we monitor the baby's anemia, the surrogate of which is what we call the middle cerebral artery, which is what you see on the right side of the screen. So the right side of the screen is an ultrasound looking at the middle cerebellar artery, and we're looking at the junction when the blood enters into the circle of Willis. And that's where we would measure it, and we look at the peak systolic velocity, which is the peaks that you see here. And then it's thrown into a normogram where it's converted into medians of the mean. And that kind of tells us whether the baby's at risk for fetal anemia. Now, so it's a very indirect way of assessing for fetal anemia, but it's what we have right now, and it's fairly accurate. So the number we're looking for is anything over 1.55 millions of the mean. The likelihood of fetal anemia is over 70%. So if we get two persistent readings into independent appointments, then we know for sure that there may be anemia in the baby. So we will now proceed to what we call the IUT, or the intrauterine transfusion. So what we do is we take Rh negative irradiated blood to make sure there are no other antibodies and wash and concentrated. And then we go in and essentially insert a needle into the umbilical vein anywhere. We try to get at the insertion of the placenta because it's the most stable area. And then we draw blood from the fetus, about 1 to 2 cc's, and then look at it in terms of the hemoglobin as our starting hemoglobin hematocrit, and then transfuse the baby directly. So the best way to treat this is to transfuse the baby intravascular, but then it's also quite challenging because sometimes there are vasospasms and it's very difficult to push the blood in. The blood we're using is very concentrated, so it's very thick as you push it into the syringe. So we sometimes have this miniature pump that we use to kind of pump the red cells in. And so if we fail, let's say our vascular access fails, then the next thing we would do is go into the peritoneum and then just deposit red cells into the peritoneal cavity. Actually, that second method was the first method that was used in the early 70s in order to transfuse the baby. So the idea was that you put in red cells into the peritoneal cavity, and then it gets slowly absorbed into the system of the baby, then treating the fetal anemia. Unfortunately, that procedure is a little bit slower. So what we're trying to do now is try to put blood intravascularly. Then before we leave or before we draw off the blood is deposit some red cells that are left behind into the peritoneum. What it does, it extends the therapeutic range of one intrauterine transfusion, which normally lasts around 2 to 3 weeks, to as much as 3 to 4 weeks, so we don't have to repeat the transfusion. Every time we start with an intrauterine transfusion, the mortality rate for the fetus increases over time. So the more we do IUTs, the more likelihood that we're going to end up with a stillbirth or a fetal demise. The other problem with IUT is that once we've done the first transfusion, our MCA that you see on the right side changes in terms of its threshold. So the MOM instead of 1.55 will now go up to 1.7 to 1.6. The data, of course, starts to change, and there's not enough data to support like how many times we can do this. So the latest data is that once you do 2 transfusions, if you go beyond 1.8 to 2 MOMs, then that anemia is persistent. After that, it's guesswork. We would do it every 10 days, we would do it every 2 weeks. We would do antenatal testing. As long as the baby looks good on the fetal monitor, we'll keep going. Otherwise, then we give steroids and we call it quits. And we hand over the baby to the neonatologist to take care of. So where we're at with technology nowadays that's starting to change our practice is that with the non-invasive prenatal testing, we can now tell the Rh antigen of the fetus. So for Natera, the panorama is what they use to look at aneuploidies, and so that's the one that that was presented in the first in the second case. So instead of just looking at trisomy 21, 18, 13 sexual aneuploidy, they can also determine the fetal Rh antigen on the baby. It has a very good literature to back it up. It's actually very sensitive. Where it fails is that if there is some kind of mutation in the RHD antigen on the fetal red cell, then this test sometimes fails. Or if there is a mutation in the mom's RHD gene, then it also fails. Then there's another test called Unity. Same concept as Panorama. They also have the aneuploidy screening, which is the trisomies. But on top of it, they can also do the fetal risk assessment for recessive carrier conditions listed on the slide here. The interesting thing about this test is that not only does it detect fetal RHD antigen, but it can also stratify and look at some of the mutations that may be occurring. So one of the things that we worry about is called Duffy, the RHD variant, which normally would come out when you do serology to be Rh positive, Rh negative, but it's actually Rh positive, and the mom can mount an immune response to that. So that's why some of the cases that we sometimes would see is that the baby would come out, they would type and screen the baby, and the baby would say Rh negative, but then mom starts developing antibodies against RHD, and that's because of the mutation that is actually not detected in the fetal red cell antigen. The nice thing about this NIPT is that it can also detect the other red cell antigens that are more common, causing hemolytic disease of the fetus and the newborn. So big C, little c, big E, the Daffy, the FYA, and Kel, the K. So it screens for all of those. And that's the reason why we sometimes would favor Unity, especially because it's not rare to see a pregnant woman that is iso or alloimmunized not only to one red cell antigen, but two or three red cell antigens. And that becomes a very confounding problem because now we have to essentially look at all those antigens and then just make a decision in terms of which one is the worst, which titer we're going to be using. But regardless of what, if it's we're not dealing with Cal, it's still 1 to 16 is still the magic number that we go for. Now, if Cal is in the mix, let's say big C, a D, and then a Cal, then we default to the Cal. So if the Cal is 1 to 4 or 1 to 8, then we start the MCA Doppler readings to assess for hemolytic disease of the fetus and the newborn. So one of the recent literature that came out was this, and this is actually basically published before the Panorama test was published in December. And this is just to assess the sensitivity and specificity of detecting fetal alloantigens. And this test that was published in the Green Journal is by Unity, and then 2 months later, the Green Journal also published the Panorama test. So by doing this, our practice is changing to the point that if you've noticed last year, there was a ROGAM shortage, and that was because there are only two companies making ROGAM in the United States. And one of the smaller company closed down because they saw that the need for ROGAM is starting to go down. And so when there was a ROGAM shortage last year, there's two companies starting accelerating their testing in terms of non-invasive testing. So in places or areas where ROGAM is a shortage, this is a nice substitute by assessing only women who actually would need the ROGAM. And then the test also does not require dealing with screening the father of the baby. So those are the two things that are very important to consider. So with this test now, you can weigh your risk and benefit, whether to use ROGAM or not, and you will know about the antigens as early as 10 weeks into the pregnancy. Of course, if there are any questions at all, then feel free to refer to your MFM to be able to assess these patients or these cases. The other thing that came into the market, or not really into the market, that's being tested, we are part of this phase 3 trial, and I'll show you what it is a drug called nipocalimab, which is this, what do you call that, purple or fuchsia? I don't know. I'm not very good with colors. I know it's not red. So this nipocalimab is a monoclonal antibody. And the way monoclonals are symbolized in cartoons like this is inverting the IgG molecule. So nipocalimab essentially blocks that IgG that may be causing the destruction of the red cell. Now, unfortunately, it also blocks all the other IgGs in the body. So that's kind of the downside. And we know that if you're very low in IgG, the likelihood of infection goes up. So UC Davis is part of this phase 3 trial. And I'm actually very happy that neonatology is now involved in it. And Emily is actually volunteered to join us in the study. So we're looking forward to our first enrollee. We have about 3 or 4 patients that are potentials right now. But then if you have anyone out there whom you think will benefit from the study, feel free to send them over so we can definitely do a consultation and an assessment. But just to show you, this is the mechanism of action of the drug. It's a 3-minute video, if you would allow me to indulge.
The most common type of antibody found in circulation are IgG, which are distinguishable by their long serum half-life. IgGs are produced as part of normal immune responses that neutralize pathogens. However, IgGs may also be involved in the pathogenesis of autoimmune diseases when they target self-molecules or tissues. Neonatal Fc receptors, or FcRns, are IgG transporters found primarily in intracellular endosomes designed to shuttle and protect IgGs. IgGs and FcRns are constantly internalized into endosomes. When the pH decreases to 6, FcRns bind and retain an IgG antibody. The unbound IgG enter lysosomes, which contain digestive enzymes and are degraded. The FcRn-bound IgG is shuttled back to the plasma membrane, where at pH 7.4 it is released back into circulation. IgG recycling through FcRn is the dominant process for maintaining IgG plasma concentrations. However, pathological IgGs in autoimmune and alloimmune diseases are also recycled by FcRn. Blocking FcRn-mediated recycling and transport may reduce pathogenic IgG levels in these diseases. Nipocalimab is a fully human anti-FcRn monoclonal antibody, which is believed to target FcRn. It inhibits FcRn-mediated IgG recycling to decrease IgG levels, including the levels of pathogenic IgG, while preserving IgG production. Nipocalimab, unlike native IgG, is aglycosylated. Therefore, it does not trigger immune cell or complement-mediated mechanisms that may damage FcRn-bearing cells. Through its Fab domain, nipocalimab has been shown to be bound to FcRn with high affinity and a high avidity across the whole life cycle of the FcRn function at both extracellular and endosomal pH throughout the IgG transport pathway. As a result, IgGs are unable to bind with their Fc fragments to the occupied FcRns. All unbound IgGs enter lysosomes for degradation. Studies show nipocalimab is expected to reduce levels of IgG, and thus it is believed to help improve the symptoms of pathogenic IgG-mediated autoimmune disorders.
So if you have anyone at all that you think would benefit from this study or have had experience with alloimmunization, we will be more than happy to talk to them. It would be nice to see them preconceptually rather than when they are pregnant earlier on, so we don't kind of hustle and try to get them into the study if they can meet the inclusion criteria.